Good afternoon, everyone. Welcome to the Yale Sleep Medicine Grand Rounds. My name is Shrutika Thapa. I'm one of the pulmonary critical care and sleep medicine faculties here at Yale. Just some brief housekeeping announcements before I introduce today's speaker. Please take a moment to ensure you're muted. And please see the instructions in the chat to receive the CME credit for attendance and a one-time sign up for a Yale CME profile to receive credit if you have not done so. And if you think anyone else would be interested in joining us, please email yalesleepmedicine.grandrounds@yale.edu. I will be moderating the session, but if you have any questions or comments during the presentation, please use the chat room, or you can unmute yourself at the end of the talk and ask the questions yourself. Recorded version of these lectures will be available on YouTube a few weeks after the presentation. And today I have the pleasure of introducing Dr. Brandon Nokes. He received his medical degree from University of Arizona College of Medicine. He completed his internal medicine residency at Mayo Clinic, Arizona, and his pulmonary and critical care medicine fellowship at the University of California, San Diego, where he also completed his T32 research training in upper airway physiology and control of breathing. Dr. Nokes is a CDA2 funded physician scientist with a dual appointment at VA San Diego and UCSD. He's currently an assistant clinical professor of medicine at UC San Diego and is the director of the hypoglossal nerve stimulation at the VA there. His research has primarily focused on upper airway physiology, control of breathing, and the intersection of obesity and sleep-disordered breathing. He's lectured nationally and internationally on sleep-disordered breathing, control of breathing, obesity-related OSA, and emerging therapies. And he's nearly authored about 50 peer-reviewed publications in leading journals, contributed to various international consensus statements, and serves on multiple journal editorial boards. He's also received numerous awards and honors, including the Sleep Research Society Career Development Award, several grants, including NIH-supported T32 funding, and a VA Career Development Award. He's also held multiple leadership positions within various societies and serves on the editorial boards. Thank you so much for being with us, Dr. Notes. And without further delay, I would like to hand it over to you to share your expertise on heterogeneity in obesity OSA interactions.
Well, thanks for having me. That was a really, really nice introduction, so thank you for that. So happy to be here. And yeah, today I'm talking about sort of the heterogeneity and obesity and OSA interactions and how those two diseases sort of overlap and how dynamic those interactions can be. For those of you who were at ATS last year, so this is sort of an update on that talk with some expansion of some of our local data that I'll add in. Here's the CME slide, which I'll give it a second just so you can get the CME code to text in. And then in terms of disclosures, none relevant to this talk. I am on an ad board for Takeda, but again, not related to this talk or data. I've got a funded CDA2 and I'm a recipient of the NIH Loan Repayment Program grant as well. So what are the objectives? So we'll talk about how the physiology of obesity interacts with OSA. We'll talk about how does sex influence this relationship? And then what happens to these interactions with weight loss? So how does obesity interact with OSA? It's complicated. It's influenced by sex, age, hormonal status, sleep architecture, body position, anthropometrics as well. And both diseases exist on a continuum. So, up first, I have this, it's an old paper by Scott Sands and colleagues back in 2014. And they were looking at individuals with a BMI greater than 25, and they looked at OSA, non-OSA, and then they had some non-OSA controls. And they said, well, what are the differences in those who are overweight, who develop OSA versus those who don't? And they looked at things like peak crit, so this critical closing pressure. And just by way of review, a peak crit device, you put on a mask and you can look at the level of pressure required for the airway to close. More positive measurements are those above atmospheric pressure. The airway can still collapse, whereas more negative means a more stable upper airway because you have to suck really hard to close the airway. So in those without OSA, but with a BMI greater than 25, they tended to have lower peak crits, i.e. more stable upper airways. And then, of course, the non-OSA controls also had very negative peak crits. And then, interestingly, they found that those, without OSA tended to have more prominent upper airway gain. meaning as their ventilatory drive kicks in, how much muscle recruitment do you get? And that was more pronounced in those who didn't develop OSA. So uh, less collapsible airways, better muscle recruitment profiles. And I, by way of introduction, so we have this clinical trial that was ongoing over the last several years, predominantly in the sort of COVIDian era, and we'll talk about that. But it was looking at individuals, with obesity, with or without OSA, and they got sleeve gastrectomies, and then we did follow up PSGs on them, and through both of those studies, we did endotyping, and there was a subset of them where we also did upper airway MRIs as well. So this is a report on sort of the baseline data of those who were sort of all comers who were recruited. And we looked at the endotype trait differences in those with class 2 and 3 obesity. So more so than the BMI of 25, we're talking about BMI of 35 plus. And what were their differences in just the preoperative cohort? So this was in Annals ATS like a year and a half ago. And the big differences we found were in BMIN, which is a non-invasive surrogate for PCRIT. So these days we use just, we derive these traits from flow signals, and we don't have to asphyxiate anyone with mask anymore to get these data. And BMIN is just ventilation at native ventilatory drive. And yet you found that people with OSA tended to have lower BMINs, i.e. more collapsible airways, less prominent upper airway muscle activity, so lower V actives. And V active is just, ventilation at maximum ventilatory drive or ventilation at the arousal threshold. How much flow can your muscles buy back? So that tended to be lower in those with OSA. V comp is just a composite metric, which is just, V active minus V passive. That wasn't different. And then loop gain, which is a measure of ventilatory control and stability, wasn't overall very different within this group. And then lastly, the arousal threshold tended to be higher in those with OSA, which is likely a consequence of disease. Oftentimes, when individuals have OSA over time, the arousal threshold goes up and they kind of learn to settle for less. And then as the OSA gets better, that arousal threshold tends to go down. But so that part wasn't surprising. Now, classically speaking, I mean, at least in the last 20 or so years, when people have talked about obesity and OSA, there's been a big focus on tongue fat. And there's this classic Rich Schwab paper where he looked at upper airway MRIs and individuals with comparable BMIs around 35. But in the individual on the left here, you see their AHI was 59, and the individual on the right, their AHI was about 9. So markedly different, and then big differences in tongue volume, tongue fat. And for a while, that's been sort of the predominant focus of how it is that OSA interacts with, or obesity interacts with OSA, is this idea of tongue fat and influencing upper airway collapsibility. Now, what we found when we looked within our slim OSA cohort, and this is, again, mostly sort of baseline individuals, about 20 or so folks in this study. And one key difference between the slim OSA cohort and the other cohorts that have been sort of explored in this space is that this cohort is about 90% female, and a median age around 43, a median BMI also around 43, and so their findings were a little different than what's sort of classically been reported. And I don't expect you to be able to sort of read through all of this correlation matrix, in rapid speed. But the big take homes were that it wasn't so much tongue volumes or tongue fat within our cohort that corresponded to changes in AHI, but individuals with longer upper airways, so more upper airway length, as measured from the soft palate to the base of the epiglottis. And that tended to be longer in individuals who had more collapsible upper airways, which makes sense and sort of fits with classic sort of tube law physiology. So that was cool to see. And interestingly, that divergence in airway length is something that has been talked about for a while. So this is actually Atul Malhotra's first paper where he looked at what are the things that sort of drive the male disposition to pharyngeal collapse, and the big thing that he found was this difference in upper airway length. But how else does sex influence OSA? Christine Wan had a great paper looking at the MESA cohort, and they did some matching of individuals within that cohort, and they found that up top here you have sort of RIM AHIs tended to track fairly well across men and women, but the big divergence was in non-RIM AHI. So there are differences in state-dependent physiology, where men tended to have a higher non-REM AHI, whereas women tended to have a lower non-REM AHI. And they tended to have differences in traits as well. So lower loop gain in women, lower arousal threshold in women, and better sort of upper airway stability, so less collapsibility, and this V passive metric, which is similar to VMen. VMen was just a native ventilatory drive. V passive is ventilation at eupneic ventilatory drive. But both measures of passive airway collapsibility, which again tended to be better in women within this cohort. And then interestingly, just sort of following up on that prior mention of there being sex differences in airway length, portending to differences in sort of local tube law and tendency for airway collapse, that difference seems to emerge at puberty. So as kids are growing up, their airway lengths relative to body height are roughly the same until they hit puberty. And at that point, there's a difference in that males tend to have longer upper airways relative to body height when compared to women. And that's also an old a tool paper and others. And then again, just to talk about how people have sort of classically thought about these sort of things. So talking about the influence of sex and age on upper airway collapsibility. So this 2008 Kirkness and Sushil Patil study showed that when you did sort of matched cohorts, as well as within the entire group, again, men tended to have higher peak crits, i.e. more collapsible upper airways. And that even holds true whenever you do, matching the cohorts as best you can. By and large, men just tended to have more collapsible upper airways. But we decided to take this a step further with modern statistics. So in 2024, we did this multiple mediation analysis to look at it. How is it that BMI influences the AHI as mediated by the endotypes? So what we did with this is so we use this news cohort, which is a clinical cohort that Chris Schmickel has assembled here. And within that cohort, we had over 2,000 individuals who had clinical PSGs that we then endotyped. And what we did was we said, okay, let's use this multiple mediation analysis to look at how BMI influences the AHI by way of the endotypes. Upper airway stiffness is just a composite metric of V-men and V-passive, and I know those are metrics of collapsibility, but bear with me, it just makes the diagram work better to phrase it that way. Dilator muscle compensation, ventilatory control, arousal threshold, ventilatory responses to arousal, circulatory delay, so chemoreflex circulatory delay. So how long does it take for a signal to get from your lungs about gut, blood gas tension changes to the carotid body and the chemoreceptors, and then how long does that sort of take for a change in ventilation? And normal is anywhere from like 7 to 12 seconds, depending on who you ask. But anyway, so looking at these graphs, so going BMI to AHI, you can see some of the direct effect, which is the bottom line here, is just not explained by the endotypes, but there's a direct relationship between BMI and AHI. But the interesting thing here is that the big drivers in men and women were different, in that in men, a lot of this was explained by changes in upper airway stiffness. So as BMI went up, upper airway stiffness went down, and as upper airway stiffness seems to be inversely related to the AHI. So and these are standardized betas, so and standard deviation differences instead of arbitrary units or whatever the individual units are. Whereas in women, BMI going up tended to decrease that circulatory delay. So, and that could be a correlate for increased cardiac output during sleep. So as your BMI goes up, cardiac output goes up, circ delay goes down. And you can see that that makes sort of short events, and that jacks up the AHI. What's interesting is that, so again, in men overall, OSA was predominantly driven by upper airway collapsibility, whereas in women, it was again changes in circulatory delay, so lung to chemoreceptor delay. But when we broke this down into women less than the age of 45, much of that mediation diagram looked more similar to men. And whereas when we looked at women over the age of 55, which we didn't have direct measurements of menopausal status, but we used that to presume menopausal status. And that's where the start delay story really sort of kicked in and looked much more like the overall cohort. Well, what about weight loss? How does this influence things? So, I mean, November of 2024 now. I mean, this was a huge paper in New England Journal. So, tirzepatide for the treatment of OSA, the SURMOUNT OSA study. And that was, run by Atul and others. And that was looking at, how is it that, weight loss through these sort of novel incretin therapies influences OSA, and they had sort of two blended clinical trials, one with CPAP, one without. And I won't go into all the details of that study, but they showed that weight loss has important impacts on OSA, and this resulted in tirzepatide getting FDA approved for obesity with OSA. More recently, and this is just in the past month, they had this multiple mediation analysis from SURMOUNT OSA where they looked at, well, if you are losing weight, how much of the change in sort of cardiometabolic risk is explained by weight loss versus changes in AHI severity? And what they found was that, so just to try to make this a little more digestible, and I know there's a lot going on, but they did sort of, composite overall, changes in body weight, AHI, and hypoxic burden. And then they had these markers of, insulin resistance, cholesterol, triglycerides, high sensitive CRP, diastolic blood pressure, and systolic blood pressure. And obviously, whenever you combined all these things, you had a larger proportion of effect mediated. But the bulk of the change was sort of in this middle category of body weight, more so than AHI or hypoxic burden, which is interesting for the majority of these metrics. And so with those things in mind, so Chris Schmickel and actually Andre Zinchuk here and Brian Wojcik was also pretty involved with this as well. We did a national survey looking at patient versus provider preferences on the treatment of sleep apnea, and how is it that patients viewed CPAP and providers viewed CPAP versus weight loss therapies. And so these are the respondents from a patient and provider perspective. So a good mix, but localized in California because we're in California, and I think a lot of our friends in their clinics tended to weigh in. But what's interesting about this is that they found that, by and large, physicians, were more comfortable with CPAP and tended to prefer CPAP as a first-line therapy for OSA, whereas patients were more like, well, hold on a second, let me try tirzepatide. So that's interesting to say, and I think most people these days would sort of view them as sort of a combo and not just one or the other. So what about surgical weight loss? Because not everyone, loses weight with GLPs. And, certainly when we were doing the Slim OSA study, that was, just prior to the takeoff of GLPs. So our friends in Australia, so, Brad Edwards and Carolyn Beatty, had this paper in Chest just a couple of weeks ago where they were looking at, pretty similar to the Slim OSA study, they combined 3 different cohorts. And they had a baseline age of around 47, 42% male, baseline BMI of 42, and baseline AHI of 43. And they looked at, after these different bariatric surgeries, how did things change? So, their BMI tended to drop, 42 to 33. Their AHI tended to drop from, 50 to 24, so cut in half. And their hypoxic burden dropped pretty markedly as well, from 84 to 30 roughly. And then when they looked at the endotypes, most of them tended to change in that the upper airway collapsibility tended to improve. So again, this is just ventilation at euphonic ventilatory drive getting better. Loop gain, so that is a scale from 0 to 1. And the higher it is, the more unstable your ventilatory control is. So that got better. The arousal threshold tended to decrease, and then muscle compensation didn't seem to make a big difference in this cohort or change in a marked way. And then what about, our Slim OSA data? So how did that compare to their cohort? And what were the differences? So at the outset, I should acknowledge, so this again was in the COVIDian era. And we had so reductions in surgeries overall, but also reductions in surgery in relation to the evolution of incretin therapies and effective weight loss medications. And so prospectively, we ended up getting about 20 pre and post-op individuals. And then, we had a much larger sort of goal in. So we said, well, all right, if people aren't getting bariatric surgeries and getting recruited early on, what if we did sort of a slicer dicer analysis and said, if you have a recent bariatric surgery and a prior sleep study, let's bring you in, try to get that sleep data, endotype it, and see how things changed after weight loss. And luckily, within this second cohort, we got 27. And interestingly, the median follow-up time for both the cohorts ended up being about a year. So they ended up matching fairly well. And so we combined them and we felt fairly safe doing that, just to sort of magnify some of the differences. They were about 43 at baseline. Baseline BMI was around 42 and dropped to 33, 34. So pretty similar to Brad's data in Australia. The fraction of hypopneas dropped a little bit, so 0.9 to 0.8. So if you still had residual sleep apnea, they're more likely to be apneic events. And then interestingly, the chemoreflex delay increased. So from 10 seconds to almost 12 seconds was a pretty marked change. Upper airway collapsibility, by both B passive and B min, tended to improve. So ventilation under both of these states. Upper airway muscle activity, not so much, and then arousal threshold tended to decrease over time. And then if you had any change in AHI, well, what drove that? And interestingly, this sort of tracks with our prior study or our prior acknowledgement of baseline chemoreflex delay being a really important part of that. But actually, I accidentally skipped over a part of this, in that we should acknowledge there was a big difference. There was one big difference between our study and Brad's, in that our baseline AHI was not so marked. Instead of being in the 40s, our baseline AHI for this group that was 90% women and 50% Hispanic was around 16. So there wasn't a marked change in AHI overall, even though these physiologic parameters were clearly improving. So, and then looking at that, chemoreflex delay, because that again seemed to be what was driving a lot of the changes. Pretty strong correlation between change in chemoreflex delay. So as it got long, as your chemoreflex delay lengthens, your AHI tends to drop, and that had a moderate correlation. So the summary of this data is that very, very different cohorts, and it's not a sort of monolith to have obesity and OSA. I think when you talk about the bariatric surgery population versus the sleep clinic population, there can be some marked differences, and I think that we captured much more of the bariatric surgery population than we would of the typical sleep clinic, which at least locally for us is predominantly men. But yeah, you can see that obesity interacts with OSA through a lot of mechanisms. This probably evolves throughout the lifespan and is influenced by hormonal status, things like menopause, et cetera. And again, obesity and OSA are not single entities, and we should keep in mind the patient in front of us when we're thinking about these two diseases that overlap and interact in pretty important ways. Questions that are unanswered. So in the individuals who lose weight but still have sleep apnea, why? And um, we're doing some active research in that space. Um, and then how do we integrate these patient-specific considerations into OSA and obesity care? And I should disclose I'm involved in the ATS guidelines for obesity management and OSA. But so stay tuned for that. And then just a quick thank you to these are all the people locally who've mentored me over the years and but Tom Malhotra, Bob Owens, Chris Schmickel, and then Jeremy Orr, who you guys saw the other week. Um, and then there's a big crew of people here also who are tremendously important to making sure that any of this research can even happen. And then this is, I should acknowledge, so Pam DeYoung, she's helping, you can't really see it well, but there's a Genie Glossus wire. So I was just looking at my own Genie Glossus CMG as I learned how to do that back in the day. And then Brian Wojcik has been huge for helping me, get acclimated into the obesity and OSA space. And he's been an invaluable resource as well. Um, and then, yeah, these are my kids. And also, I should thank my wife as well, because she's had to listen to a lot of talk about floppy tubes over the years and still loves me for some reason. So thanks, everyone.
Well, thank you so much, Brandon, for talking about this, fairly novel idea and, sharing your excellent work and ideas. Really appreciate it. I don't see any question, but I had a question. So, we talked about obesity, OSA. What about obesity-driven OSA differing mechanistically from OSA in non-obese patients? And, does that really matter? And then, for clinicians in everyday practice, anything that you would say, that needs to be thought about regarding the obesity, OSA heterogeneity, that we should take into considerations in managing patients, like, beyond BMI, anything else that should be taken into. I know the peak rate is something that you talked about, but not something that we can, do it in our day-to-day practice. But any thoughts or any that you would like to share?
Yeah, I mean, as much of an upper airway and OSA nerd as I am, I hate to acknowledge that I think obesity is probably the more important of the two diseases. But I think also as people move forward in this field and as newer weight loss medications continue to come out, that's going to be a routine part of our practice, and we should be comfortable learning how to manage obesity within the sleep clinic, um, and not shy away from these things that are new. It's not that steep of a learning curve to get involved. The neuroscience of obesity is really cool, so that's fun to dive into. And then in terms of obesity and OSA, so it's thought 40 to 60% of OSA is attributable to excess weight, at least in part. So it's not going anywhere, and then you should also consider that that's only 40 to 60%. So there's still a lot of other people who have OSA for other reasons. Um, and then likewise, there are plenty of individuals with obesity who don't have OSA, as we showed. So yeah, individualizing the therapy really seems to matter. And then just to mention, yeah, it's probably good that we're not doing peak crits anymore, because it's really it's hard. You're like in the lab till like 4 a.m. and then you're asphyxiating people, so you feel kind of guilty about it. So at least I did.
Great, thank you. By the way, those are lovely pictures of your kids. They're really cute kids there. So I have a question here from Stuart Min. Is the weight issue the major factor determining the hypoxic burden in patients with identical AHIs?
I think so. Yeah, and whether or not that's related to tendency for like VQ mismatch, et cetera. It's very tempting to say, but I do think so. Yeah.
Um, Anyone has any other questions? Please feel to unmute yourselves, or you can type it here. I don't see any other questions. Um, uh, Maybe I did not catch it. So when you were talking about the length of the airway, could you talk a little more about that, the correlation that you guys found with the length of the airway in men?
Sure. Yeah, just I mean, longer upper airways are more likely to collapse.
Are
And
more prone to collapse.
mhm. So as your upper airway length goes up, your tendency for airway collapse goes up, and that difference seems to emerge between men and women at puberty, where men tend to get longer upper airways relative to women. And then even within women, a longer upper airway also can drive to collapse because as you saw, our cohort was 90% women, and that was still something that predicted a tendency for a more collapsible upper airway and a higher AHI within that small cohort that were able to get upper airway MRIs.
And then in women, the circulatory, like how did that increase AHI? The thing that you showed, I couldn't. I'm sorry, but it's a
Yeah,
really novel idea there. So,
no, yeah, it's cool. So like as nocturnal cardiac output goes up, that means that your circ time between your lungs and your chemoreceptors goes down.
yeah,
And if you're looking at someone's like saturation tracing instead of having these slow desats, rapid and slow resats, it's a more of like a desat, reset, desat, reset, and that you can
yeah.
see that jacking up the AHI pretty quickly. So it shortens the event duration. Um, and yeah, Priya Borkar has written a lot about this and had a cool paper in the Blue Journal with Susan Redline a couple of years ago. Um, but yeah, it's not novel in the sense that people have known that short circ times tend to increase the AHI. But what is interesting is the potential sex and age differences and how that relationship evolves.
So it's just because the circulatory time is short, you're detecting the desaturation faster, and that's sort of increasing.
Hmm.
Got it. Okay. Thank you. It's
Of
really
course.
helpful. I don't see any other. Oh, here. By Denise McCall, is there a relationship between airway length and the level of CPAP required for treatment?
Um, I don't know off the top of my head. But I can look that up. I know like Mike Stanchina, I think did some work in that space some time ago. And then some of the folks in Australia have also sort of looked at like rubber tubes and sort of chambers to see how different sort of tube law interactions interact with OSA. But um, in terms of the airway length and the pressure required, I don't know.
To be determined in the future.
The data's probably out there. I don't know it off the top of my head.
All right. If no one has any other questions or comments, we will be getting their 25 minutes of the time back from Dr. Noakes. Thank you so much, Brandon. I really, really appreciate it. This is really fantastic learning about what you shared with us. Yeah, thank you again.
All right. Thank you all. Thanks for having
Thank you,
me.
everyone.